Let's start. Thank you all for joining. Hello, everyone. Today is our first Journal Club debate. I'm titled, Is ConOS the Answer? So hello to people who may be watching this on YouTube later. As always, I'm very grateful for such an excellent support team for Journal Club. Lots of people are working behind the scenes. And obviously, the main reason why we're able to provide what I think is quality content is Dr. Galandiak's supervision and leadership. Please find our disclaimer. Usually we have more people joining. We're up to 35 participants now. I'm sure we'll get a few more. Please feel free to comment in the chat and ask any questions. So the aim of this debate is to have a robust discussion about the pro and cons of the ConOS anastomosis and the operative management of patients with enteric Crohn's disease. Two teams, both have 3 speakers, will explore the merits of adopting the anastomosis, and each set of speakers will have an impartial judge to make comments as well. We're going to have 2 separate rounds. One is the main question round. The main questions have been provided to the speakers 1 week ahead of time. And then the lightning round is clinical scenarios that have not previously been shared. With the main question, we have the first speaker that will have 4 minutes to state their arguments. Then the opposing speaker will have 1 minute of rebuttal and 4 minutes to state their arguments. And then the first speaker will have 1 minute for a rebuttal. And then we'll ask the nominated judge to pose 1 follow-up question to each of the speakers, and they will have 1 minute to answer it. The question can be something that they prepared earlier, or hopefully it might be something that's triggered by the chat. Each set of speakers will alternate in terms of who's going first, the affirmative of the opposing teams. And to ensure fairness, we'll have a clock, and we will give the debaters 20 seconds notice. And unfortunately, going over time will not be possible. Just briefly, one of the earliest publications about the ConOS anastomosis was in the DCR journal, perhaps a reflection of the journal's ethos, and the fact that innovation is held in the highest regard. The technique of ConOS, as per that publication, is described here. In diagram A, the nearby mesentery of the intestinal loop that is to be excised is divided at the mesenteric wall of the bowel with a vessel sealing device. Diagram B shows that the intestine is transected by using a linear staple cutter, such as the mesenteric side is located in the center of the stump at 90-degree angle to the mesentery. Image C demonstrates that before the anastomosis, the stumps are sutured together to create a supporting column. Images D and E demonstrate longitudinal enterotomies that are performed in an antimesenteric aspect about 1 centimeter from the supporting column. And image F shows the anastomosis is created in a transverse hand-sewn fashion and is about 7 to 8 centimeters wide. Next slide. Dr. Kono passed away last year after a battle of with hepatobiliary cancer. You can find an obituary written by Dr. Fiqueira and published in the DCR journal in March this year. I personally have never met Dr. Kono myself, and I do not mean to bias the debate or the outcomes of the debate. However, I think it is important to recognize a surgical innovator who has clearly had a major impact on our profession, as well as what will become apparent is that we will discuss a couple of the current randomized controlled trials that are run by 2 of our debaters. And of course, the randomized controlled trials wouldn't have been here if not for the anastomosis in the first place. Next slide, please. So now it gives me great pleasure to introduce our debaters and judges. They are all incredibly accomplished, and I'm very grateful that they have dedicated their time to support the Journal Club. In fact, I'd probably use up more than an hour to sort of describe the academic achievements of each one. So in the interest of time, I'll be very brief. On the affirmative team, we have Dr. Crane. She is an associate professor and chief of the colorectal surgery section at the University of Washington Medical Center in Seattle. Speaker 2 is Dr. Stefan Hollebar, who is the chief of the IBD section and director of research at the Department of Colon and Rectal Surgery in Cleveland Clinic, Cleveland, Ohio. Speaker 3 is Dr. Michelasi, who is the surgeon-in-chief in the New York Presbyterian Weill Cornell Medical Center, as well as being the professor and chairman of surgery in the same institution. He is also the principal investigator of the prospective randomized study of the CONOS anastomosis versus the side-to-side functional end anastomosis in the prevention of postoperative recurrence of Crohn's disease. The estimated completion date of the trial is March 2023. And Dr. Michelasi, I've been told that the submission process at the DCR journal is very seamless. So it might be something to factor in later next year. Next slide. On the opposing team, we have Dr. Massaris. He is the chief of colon and rectal surgery at the Beth Israel Deaconess Medical Center and is the associate professor in the Harvard Medical School in Boston. Dr. Lucas Stocky is the professor of surgery and the current chair of the Division of Colon and Rectal Surgery in the Department of Surgery in the Mayo Clinic, Florida. And Professor Stephen Brown, who is the professor of surgery at the University of Sheffield in the United Kingdom. I'm particularly indebted for his attendance, as not only because he's fronted up so soon after the 0-0 draw between England and the USA, but because it is the middle of the night in the UK. Professor Brown is the chief investigator of the MEERKAT, which is the mesenteric excision and CONOS anastomosis trial. The trial is estimated to conclude by April 26, and of course, we're looking forward to hearing about it in our discussion. Next slide, please. So we have 3 judges. Dr. Hyman is the or immediate past president of the of the American Society of Colon and Rectal Surgery. He is the professor of surgery and chief of the section of colon and rectal surgery, as well as being a co-director of the Center for Digestive Disease in the University of Chicago. Dr. Silla is the president-elect of SAGES. She is the professor of surgery at Mount Sinai Hospital in New York. And Dr. Aguera, who is the chair of the Digestive Disease and Surgical Institute at the Cleveland Clinic. He is a gastroenterologist, so we will not hold this against him. And he is also a professor in the Department of Medicine, Case Western Reserve University, Cleveland, Ohio. Next slide, please. The next 3 questions are the main questions as described. The first question is, the anatomical configuration of the CONOS anastomosis is superior to other types of bowel anastomoses. Dr. Crane, Dr. Massaris, and Dr. Hyman are involved in this, and Dr. Crane is on the affirmative, and she will start. Thank you.
Thank you for inviting me to speak about something that is very near to my heart. So I think that anytime you read a paper on surgical management of Crohn's disease, the preamble will state that up to 80% of patients will require surgery in their lifetime. Of those patients, 30 to 40% will have reoperations, usually due to recurrences that occur at the anastomosis. While we're making some headway with medical management, a surgical fix to decrease recurrence has been elusive historically. We've looked at numerous types of anastomoses, side to side, end to end, and while there have been numerous debates on this topic, I think most of us agree that a wide anastomosis is what we would want to achieve, and most of us historically have done that through through a side to side technique. There are, however, issues with the side to side technique, particularly when there is recurrence of disease, because there can be angulation through the configuration of the anastomosis that causes fecal stasis and can make it quite difficult to evaluate endoscopically, let alone intervene upon. So only if there was an anastomosis that could combine the benefits of the end-to-end configuration and the wide lumen of the side-to-side. And lo and behold, thankfully, our esteemed colleague, the late Dr. Kono, created such an anastomosis in 2003. I just want to show the image that had been shown previously for those of you who have not seen the CONOS or done the CONOS anastomosis in the past. It is essentially based on 3 principles. The first is that the mesentery is divided close to the bowel wall. And while there may be some controversy regarding this, the thought is the benefits are maintaining the innervation and blood supply to the anastomosis. The second, and probably what is most different, is creation of the supporting column. So the bowel is transected not parallel to the mesentery as is our standard approach, but perpendicular to the mesentery. The corners are then imbricated and sutured together. And what this allows is the creation of a supporting column that will be posterior to the mesenteric aspect of the anastomosis. This allows for the ability to maintain the orientation and configuration. It prevents torquing of the anastomosis, particularly when there is a recurrence, which we know tends to occur on the mesenteric aspect. This not only allows for the orientation to stay when there is recurrent stricturing disease, but also prevents the torsion that can sometimes be the root of the obstruction. Lastly, the anastomosis is created with a wide lumen. So longitudinal incisions are made so that there would be a transverse anastomosis with a diameter of about 7 to 8 centimeters. It's created in whichever way you do your hand-sewn anastomosis. So this can be 1 layer or 2 layer. And because of that, once you understand the orientation, it's actually a very short learning curve. So most people, this truly can be a see one, do one, teach one anastomosis. My esteemed colleague may say that this prevents you from being able to do minimally invasive surgery, and I would argue that the entire mobilization, even the division of the mesentery, if you feel comfortable, and transection of the bowel can be done through a minimally invasive approach. The extraction site is often dictated by the size of the specimen due to phlegmon and associated inflammation and fistulizing disease. And so I can often do the hand-sewn anastomosis through the extraction site itself. As you can see, the creation is relatively intuitive and has several benefits associated with it, most notably a wide lumen and decreased torsion and maintenance of the orientation. Thank you.
So thank you for ending on time for the first one. I'm just learning.
Thank you very much. Now we have Dr. Messeris with the rebuttal, please.
First of all, I would like to thank everybody for being here. Thank you for inviting me, Dr. Crane. It's an honor to go against you. We're from the same class, actually. So Dr. Crane told us the good things about CONOS, correct? We exclude the mesentery that could cause a recurrence. You're creating a tissue-free anastomosis, a wide lumen, and an isoperistaltic anastomosis. I'm going to argue that you can do that in another way also. Now, she didn't tell you the bad things. How much time does it take to make that anastomosis? It takes usually around 50 to 60 minutes for an average surgeon to do the whole anastomosis. You need more mobilization than you would do for any other anastomosis that you could do. Stapled, laparoscopic open, you need more mobilization in order to achieve what you need. Laparoscopy, as you said, and you agreed upon, Dr. Crane, is very challenging in these cases. And you cannot tell me, even if you do extracorporeal anastomosis side to side, that it's the same with doing a CONOS, because obviously it's not, needs more time and more freedom. You need a larger incision in your laparoscopy, and you need a learning curve. You can do a side-to-side for everything. You cannot do a CONOS for everything. And the significance of the clinical utility, I think we're going to discuss later. Furthermore, I think it's important to keep in mind whether we remove or we don't remove the mesentery extensively based on how Dr. Kono reported initially or how things have evolved over time. What causes anastomotic recurrence in these cases? Microbiome with the fecal stasis, the increased transit time and the impaired mobility that you have, especially in the side-to-side anastomosis, and also perianastomotic factors like ischemia, the denervation, the size of the anastomosis, and the extent of mesenteric disease that Dr. Crane did not mention, because not the same to have a mesentery wrapping the whole small bowel and be thickened versus a case where things are much softer and it's not wrapping. Finally, what was not mentioned is postoperative prophylaxis. I'm talking about the trials that we're going to discuss in the future. Less than 50% of the patients in these trials received actually biologic treatment. Moving on, what other options do you have? You have a side-to-side anastomosis. You have a side-to-side isoperistaltic anastomosis. You have an end-to-end and a side-to-end. I'm going to start fast. I wish I could have slides to show you, but the end-to-end anastomosis, I'll start with the easy part. this in all the reviews, randomized trials and systematic analysis is the worst in overall outcomes and overall in the recurrence outcomes for Crohn's disease recurrence. However, I want to remind everybody, when you're doing a hands-on anastomosis in 2 layers, not a single layer that you could do the colon S, you exclude actually the mesentery by doing the posterior column, the external opening with interrupted silk sutures most of the times. You exclude completely the mesentery when you start at anastomosis to do it. So that's an interesting point. This anastomosis, despite the exclusion, has very high rates. Side-to-side anastomosis, we all do it, stapled. There's no mesenteric exclusion unless you try to do complete anti-mesenteric to Taenia coli anastomosis. It's familiar to everyone. It's much faster, 7 to 15 minutes to do it, and it is more difficult to surveil endoscopically. Isoperistaltic side-to-side anastomosis, I think your attention needs to be drawn here. Here we have an anti-mesenteric to anti-mesenteric side. The mesentery stays completely far apart from the mid portion of the anastomosis. It doesn't touch it anywhere. It has no transit delay, no stasis. Probably the transit, I know Dr. Fouquet has tested this in side-to-side versus cono-S, but in isoperistaltic is faster than the cono-S, and it takes 1/3 of the time to do it, and it's easy to surveil. A couple of things about the mesenteric excision. Dr. Coffey described that if you remove the whole mesentery versus if you remove exactly like the cono-S anastomosis, only the edges of the mesentery, at 4 years, reported the same surgical recurrence with the randomized trials from Italy in regards to cono-S anastomosis. So is it true? Is it just the cono-S anastomosis? Is the exclusion? Can we just get the mesentery and do a side-to-side and be done? And finally,
I know it is a tough clock. We think it runs a little fast, but it probably is uniform between people. I'm sorry for that.
5 seconds. Can I get 5 seconds?
Please finish your sentence.
Okay. So cono-S needs more time, more effort, longer learning curve, bigger incision with questionable lower surgical recurrence rate. I personally support it for selective cases. The very high-risk cases should get cono-S. But for the rest, I don't see the reason to do it. Thank you.
All right, Dr. Crane, I'm going to start your 1 minute and 10-second rebuttal.
So as expected, Dr. Maceras is a very worthy opponent and brings up a lot of good points. So let me, in 1 minute, go over each one of them. I've been doing this anastomosis personally for over 12 years, and I will say that it can be done for any anastomosis. It can be done for small bowel, ileocolic, even ileorectal anastomoses. The second is that the learning curve is actually quite brief, and I don't think it adds 60 minutes. I think most of us can do a hand-sewn anastomosis in 20 to 30 minutes. In addition, I would argue that very often the length of the extraction site, no matter how you're doing the mobilization and the anastomosis, is dependent on the specimen itself. The mesentery is thickened, there's often a phlegmon, and so it is incredibly rare, if ever, that I have to lengthen the anastomosis, lengthen the extraction site in order to make the anastomosis. It's quite large just with the specimen itself. I would argue that you may have to mobilize a little bit more, but I think it is not difficult to mobilize the hepatic flexure, and the small bowel obviously requires no significantly increased mobilization. Lastly, it is very easy to endoscopically surveil and do dilations if needed compared to.
Thank you very much for that. Now, if we can possibly have Dr. Hyman to ask a question of both the debaters, one at a time, please.
Okay, well, Dr. Crane and Dr. Maceras, what a pleasure to listen to both of your talks. I'm going to sort of ask you both the same question. So, Dr. Crane, I like to sing Sinatra when I'm doing the anastomoses. What evidence of any kind do you have for anything that you said in terms of that the angle's different with this, what are the critical features of recurrence? How can we be talking about maintaining blood vessels and nerves and mesentery and orientation? Dr. Coffey says we need to maintain the remove the mesentery. You're saying it's important with Kono that we maintain it. So what evidence is there for any of the purported benefits of this anastomosis other than wondering aloud?
So I think that's a great question. I mean, I think the evidence occurs in you can see it in the data, both single institutional and multi-institutional studies, as well as the randomized control trial that recently came out of Italy. I think we're all looking forward to Dr. Michelassi's results as well. What we know is that there is a decrease, and it will be discussed in the next debate, but that there's a decreased risk of surgical recurrence. Even if the endoscopic recurrence is the same, there's a decreased risk or decreased occurrence of surgical recurrence. And I would argue that's because while we may not be preventing completely the recurrence of the disease, what we're doing is maintaining the orientation, and the lumen is wide enough that even when there is a recurrence, we have a time delay before somebody would need an operation. The proof is in the pudding. All you have to do is scope these patients. So if you scope a side to side or in a standard end-to-end anastomosis, especially when there is recurrence of disease, it's vastly different than the trumpet-like configuration of the Kono-S anastomosis. It is wide open and for all intensive purposes, very easy to dilate.
So Dr. Meszaros, you've similarly gone through a variety of your theories on what you think is important. What evidence do you have for any of your insertion? What evidence do you have for any, basis, or, how do we know that if we don't know what the principles are of what causes recurrence, how do we know that Kono is the best? Maybe we should have the Kono R or the triple P, or, what is the basis for any of your musings?
So when I see a randomized trial, that the Italian trial, I check two things. First of all, what are the numbers on the control group? Do they look like our numbers? So I'm just going to mention the numbers. This is for side-to-side anastomosis. Endoscopic recurrence, 65% at 2 years, 30% clinical recurrence at 2 years, and 4.6% surgical recurrence. By the way, that was not statistically significant, Dr. Crane. Easy to say there was a difference, but there was not. If you power the randomized trial to prove significance for surgical recurrence, you need 150 patients in each group. They had 36 and 46, if I remember well. We don't have these numbers. I don't know if anybody in the group does, but I don't think we have 67% endoscopic recurrence. We might have 30% endoscopic recurrence at 2 years. Also, we protect our patients differently post-op. We use biologics. In these studies, there were no biologics. Only less than 50% of the patients got them afterwards. I'm waiting for Dr. Michelassi's trial till I start changing my practice for all patients.
All right, good first round. Thank you everybody for keeping well on the time.
Thank you. Exactly. Thank you very much for that. Let's have our next slide, please. So our second question is, based on the available evidence, are you ready to adopt the Kono-S anastomosis? The affirmative is Dr. Holliber, the opposing is Dr. Stocky, and the judge is Dr. Silla. If we can have Dr. Stocky start. Thank you very much.
Thank you, Vlad. Thank you all for the invitation. I realize that this technique might be the future of management of Crohn's disease, but I feel by character skeptical until there is stronger evidence. And to piggyback the outline of the only prospective randomized trial mentioned and discussed by Dr. Meszaros, I feel that the evidence is so far insufficient. Again, if Professor Michelassi's results are out in March, it's a short time, and we will have more corroborating evidence. So I could become a convert. So it's difficult for me to say I'm against it, honestly. It might be a good idea. I think that by character, I tend to be skeptical, and perhaps I should have more faith. There are certain situations that I've seen, I've read about, I've studied and in part practiced, where there was a lot of hope for a new technique, and the data did not support that. For example, a few years ago, there was enthusiasm about doing a side-to-side staple anastomosis in Crohn's disease because it would be a wider anastomosis and therefore delay recurrence. But the prospective randomized trial that was intended to be a multi-center trial did not accrue a lot of patients, and most importantly, did not demonstrate a superiority of that type of anastomosis over a hands-on anastomosis. There are other, outside of Crohn's disease, there are other situations where we as surgeons had hoped for a new technique to be success, and it didn't work like that. For example, I am guilty to have done transverse coloplasty for rectal cancer, and when the data came out, it was no benefit. But for a few years, a number of colleagues, including myself, were recommended to do it because the function would be better. Other examples of techniques that didn't pan out are laparoscopic lavage for perforated diverticulitis. Again, it can be done, but it's not so clearly superior. I think that as the data accumulates, it's not so clear. And I think supreme is, at least my practice, hemorrhoidopexy, stapled hemorrhoidopexy was supported by a prospective randomized trial, and I personally have stopped doing it. In that case, it might just be that I'm not good enough to do it, or in my hands, it doesn't work like the data that I read in that trial. So again, I am convinced that it's a good technique. It doesn't impair a patient's health. I'm not convinced about its superiority, but in the future, I might be. Thank you.
Thank you very much for that. Dr. Hollowell, please, your rebuttal.
Thank you, Vlad. And thank you to everybody for tuning in tonight. As you know, my dear friend Luca, we should all strive to have evidence-based practices, whether it be for VT prevention, using enhanced recovery to optimize patient care, or in this case, to prevent postoperative recurrence of Crohn's. Until recently, no randomized trial demonstrated the superiority of any one surgical anastomotic technique with respect to postoperative recurrence of Crohn's. However, the Supreme Crohn's disease study by Gaetano Luglio et al. Demonstrated that CONOS was independently associated with decreased postoperative recurrence relative to side, and we'll go through that data a little bit more. It's important to note, without treatment, the endoscopic postoperative recurrence rates are in the range of 60 to 80% historically, and this was indeed observed in the control group. While the CONO group, the endoscopic postoperative recurrence rate was only 20%, so 1/3. Furthermore, they did not find any differences in short-term safety outcomes attesting to its safety. More recently, 2 meta-analyses on CONOS have been performed, both suggesting the superiority of the CONOS. The more recent one included about 900 patients and showed that the CONOS was associated with an order of magnitude lower rate of both endoscopic and surgical postoperative recurrence. These meta-analyses also found that the CONOS was associated with a very low anastomotic leak rate, about 1%, as opposed to 9% in the other group. I do note, and thanks to Scott Strong for pointing this out to me earlier today, that the CAST trial had a leak rate of 7%. And the NERI study, which was a NISQIP study of high-risk ileocolic anastomoses that we published several years ago, showed a national average leak rate for Crohn's ileocolics of over 4%. If the CONOS can consistently be shown to be associated with a leak rate around 1%, that alone would be reason enough to adopt it. So with respect to the adoption of the technique, largely based on a Luglio study, and in response to the high volume of redo ileocolics that I see in my practice, several years ago, I adopted the CONOS and found this to be a safe procedure, one that the colorectal residents love to perform as it's hand-sewn, and also they typically have not been exposed to it yet in their careers. And since adopting this several years ago, I've performed dozens of these, and we have an abstract in preparation of about 120 CONOSs, and we too have observed a very low, lower than traditional methods, leak rate around 1%, and to date, an endoscopic recurrence rate of about below 20%. You know, I think I prefer the CONOS personally for several other important reasons. We note that the referring IBD GIs, lest we bite the hand that feeds, also prefer this anastomosis for several reasons. First, it's evidence-based. The GIs live and die by RCTs of their new medications. You know, it's important to note that most of the biologics have an efficacy of about 15%. That's an attributable benefit of about 15 to 20% above placebo. So any method that we have to reduce the post-op recurrence should be pursued, in my professional opinion, especially for us. If it's relatively easy to perform, it's less costly than a totally stable anastomosis because you're using less staple loads. And as discussed, it's it may be an order of magnitude lower post-op recurrence, as shown by the Supreme Crohn's disease study. Second, for the endoscopist, as mentioned by Dr. Crane, it's much easier to endoscopically intubate relative to side, and this is especially important given that the post-op recurrence typically occurs in the afferent limb. So it's really important to actually be able to intubate the afferent limb easily. Whether the LUGIO results with respect to post-op recurrence prevention will be validated by the study by Dr. Michelosi remains to be seen, but from my point of view, we have enough data to adopt the Cone-OS, especially in high volume centers and in high-risk phenotypes such as their prototypical young male with penetrating disease, and also in those with recurrent disease. Thank you.
Thank you very much for that. Dr. Stocky, you have a minute to counter-argue, please.
I don't want to make the journal club boring, but I respect Stefan's points, and if it works for him, certainly what he has published is excellent results. I read his article on DCR. So again, I respect that, and I might become a convert in the future. I think the specifics of the prospective randomized trial were already eviscerated by Dr. Messari. So I congratulate Lulio, and I don't know him personally, but I discussed personally with Dr. Fichera the benefits of this anastomosis. He introduced me to Dr. Kono. I mean, I've been hearing about this for quite some time, and I just would like to see more convincing data in all the parameters that Stefan mentioned, and then I'll start doing it. And as pointed out by Dr. Crane, I think that unlike other techniques, I think it's possible to switch from whatever somebody does to this without a lot of learning curve. So hopefully, again, one day I will be a convert.
Thank you very much for that. Now, Dr. Silla, if we can have you direct a question to each of the speakers, please.
Well, thank you for the opportunity to weigh in as a judge. As a spectacular job and brought some really good point. So I have at least one question for Stefan. You know, everybody keeps talking about the short learning curve, but we clearly know that besides the evidence available, you know, to sway surgeons to change their technique, there's always going to be an increased rate of complications when you start adopting a new technique. So is there ever going to be an evaluation of the first 10 surgeons, first 10 cases showing the actual actuarial complication rate in terms of anastomotic leaks or time? Because I think that kind of data will really help convince surgeons that it really will take anywhere between 1 and 10 cases to get really comfortable and to bring the OR time down. I have not seen a single learning curve paper, you know, speaking on that topic.
Yeah, I agree, Pat. I haven't seen anything on the learning curve. It's a great idea, and it's definitely needed. I can tell you from my personal experience, it was like Dr. Crane said, a C1, and not even C1. I mean, the papers are very well by Dr. Kono, describe the technique in gory detail. And for anyone who can use a TA or a linear stapler and understands geometry, basic geometry, and also, I think very importantly, probably most importantly, is facile with hand sewn. And I think that that is probably one of the biggest benefits of the Cone-OS, especially if the studies ultimately show that there's no difference. It's causing a resurgence in hand sewn technique. And as we all know, there's some cases that you just cannot staple. There is no choice but to do an end-to-end. And I think that that's one of the, the extra benefits of the Cone-OS is that our fellows are now being exposed to a higher volume of hand sewn that they have in previous decades. Luca is a dear friend of mine and I respect him very much. And I agree with him. I'm not completely convinced. I think we do need the randomized trials to give us the definitive answers that we need.
Can I ask a question to Luca?
Sure, you're the judge.
Yes, just so considering you're still weighing your options in terms of adopting this technique, what do you think of Dr. Brown's really, I think, very interesting proposition of it might be the mesenteric excision that actually makes the difference, so that actually may amplify the results of CONOS? So will you wait for the evidence from Dr. Mitikalasi's study before you adopt CONO, especially if it shows lower recurrence rate? Or will you wait to see some data coming from the other trials, MERCAT among others, looking at the potential impact, in and by itself of doing mesenteric dissection? What is your take on that emerging technique?
I mean, if the data comes out in March, I could become a convert in March. So that's 4 months from now. I mean, if I had to start doing TA, TME, that would need a long learning curve. I think I'm more comfortable to switching to CONOS. So that, I might be wrong, but that doesn't concern me as much. I think that the point that you're making raise a additional layer of complicating variables, because as Dr. Crane pointed out, the original technique indicated and proposed, and also Dr. Hyman pointed it out, that the mesentery should be left close to the bowel, whereas there is this opposing view that the coffee and mesenteric excision is the key to recurrence. And I realized that the paper by Stefan indicated the sort of combination of the two. I'm also waiting for the results of the trial from the Jingling group in Nanjing, which has been a proponent of this. And so hopefully that will clarify the impact of the mesentery on the anastomotic technique. But I think that I would keep for the time being the mesentery on the shelf and just see one step at a time, what the anastomotic technique results are. And that to me is the next step.
Thank you very much for that. Let's have our next slide. So our last long question is 10 years from now, will we view the CONOS anastomosis as a durable option that withstood the test of time? The affirmative is Dr. Michelasi, opposing is Dr. Brown, and the judge is Dr. Reguera. Dr. Michelasi, if you can please start when you're ready. Thank you.
Well, thank you very much, Dr. Bolshinsky, first of all, for your kind introduction, and also for reminding me that the submission process of DCR is seamless, something I know quite well. And now I think I'm going to date myself. I published my first report on the side-to-side isoperistaltic strictureplasty on DCR 30 years ago. So first of all, let me also thank Dr. Galandiuk and the organizers of this debate for their kind invitation to participate. I'm really honored to have been paired with Professor Brown and with Dr. Reguera. So to answer the question, 10 years from now, will we view the CONOS anastomosis as a durable option that withstood the test of time? I would like to answer, I surely hope so. It would mean that for the first time in the history of surgery, we surgeons have the ability to reduce the anastomotic recurrence rate in Crohn's disease. And the data are encouraging so far, but not definitive. Let me just review the data. There's some 15 original publications on CONOS to date. 12 are original series, and 3 are meta-analysis. The best meta-analysis is from Nguyen Chen from Singapore, published last year. After a thorough review of the literature, they collected data from 9 articles. With more than 600 patients, the authors reported a 5-year surgery-free recurrence rate of 97%, which compare favorably to the 76 5-year surgery-free recurrence rate after conventional anastomosis. Regarding the safety of the anastomosis, has already been mentioned. The authors reported a 0 mortality rate, an anastomotic dehiscence rate of 1%, anastomotic bleeding of 1%, postoperative ileus of 3%, 8% superficial and deep organ infections. All these rates were either lower or comparable to the rates obtained after a conventional anastomosis. Hence, we can say that pooled evidence from available studies shows the promise of reduced surgical and endoscopic recurrence. But the evidence is not conclusive. 8 of the 9 articles were observational in nature, both retrospective and prospective, and only one was a randomized control study, the Supreme study from Italy, from Dr. Gaetano Luglio. The original article by Kono in 2011 and the article by Shimada, both from Japan, had a mix of cases in terms of location. There were jejunal cases, ileal cases, colonic cases. Both of these articles and the Supreme study had both primary and recurrent disease. The Supreme study had a very short follow-up, 24 months. No wonder there was no difference in surgical recurrence between the 2 arms. And the primary endpoints were endoscopic and clinical recurrence. They were not surgical recurrence. So, and all of them, let's just remember this, all of them were underpowered. The additional 4 original series published since this meta-analysis suffer from the same problems. Hence the need for a randomized controlled trial, which we started several years ago, and it is nearing completion of enrollment. And I firmly believe that that study and the MeerKAT, led by Professor Brown, will hopefully answer the question in a definitive way. Thank you.
Thank you very much. What perfect timing. Dr. Brown, can we please have your rebuttal? Thank you.
Yeah, thank you very much. And thanks for the invite. And for the purposes of winning this debate, I wish the US the best of luck in their match in a few hours' time. It's a great honor to be debating with Dr. Michelesi. Great respect for him. And actually, we don't disagree on a lot. And thank you very much, Dr. Michelesi, for pointing out the poor quality of the data when it comes to the Colon anastomosis. I think what we can say from the data is that Colon seems safe. Several cohort studies suggested this is the case, and I believe the evidence is strong enough to be credible. Indeed, why shouldn't it be? Because it's just an amalgamation of long-standing techniques that we can all do. As regards the hypothesis to why it works, well, it could be credible. It certainly involves an anti-mesenteric anastomosis, and this fits with the anatomy and the collateral supply of the anti-mesenteric border, and also fits with the fact that strictureplasties seem to have a very low site-specific recurrence. Of course, we think that recurrence occurs in the mesenteric border. We've never really proved that in humans. We proved it in animal studies. I'm not so sure about the other aspects, and this has been touched on before. Exclusion of the mesentery, okay, maybe. Close mesenteric ligation, well, there are other studies that suggest would be more radical with the mesentery. Why should that protect the blood and nerve supply to the border edges? It really makes sense to me. A supporting column, well, might make sense, but never really been proven, no evidence to back it up. And the hand-sewn anastomosis being more flexible sounds pretty dodgy to me. They're all a bit lacking in the evidence. And we know that recurrence, when it does occur, it occurs on the mesenteric, the anastomosis itself, or just proximal. And I think perhaps the Colon works because it's a wide open anastomosis and reduces stasis. If it's going to be around in 10 years' time, will it be the same? There might be some modifications. The degree of mesenteric resection is something that's certainly being debated at the moment. Whether we should be doing a hand-sewn anastomosis, it certainly takes longer, and that's been touched upon before, but why not do a stapled anastomosis? Will it make any difference? And some people have described that. Indeed, robotic surgery, the robotic surgeon gurus tend to do a continuous suture. Is that going to make a difference? So I think we need more evidence and more robust evidence if we're going to take on the Colon anastomosis, and if it's going to be around in 10 years' time. Now, Dr. Michelesi has pointed out the evidence and the quality of it. We're relying at the moment on one randomized controlled study with pretty astounding results and a very high rate of endoscopic recurrence in the control group. Now, just to correct one of my previous speakers, it was 66% at 6 months, not 2 years. So that's quite high. The way that we assess endoscopic recurrence is using the Rutgers score. It's been around for 30 years and it's got some issues. It may well be overcalling recurrence in stapled anastomoses. The modified Rutgers score takes that into account. Luglio did not use that. So it may be that he's overcalled it. Don't forget, he didn't blind his endoscopic assessors. So there's a serious element of bias in his study, and that might explain this high recurrence rate in the control group. Also, don't forget that Rutger score is not designed to incorporate different configurations. It was in the days when we just do an end-to-end anastomosis, and it's quite difficult to assess recurrence with the newer techniques. Now, I'm looking forward to Dr. Michele's study, and it may well change our practice. I hope it's going to be a positive result. I've also got a trial running called the Meerkat trial, which I think is slightly more future-proofed in that it also includes the mesentery. But if you're going to be a researcher, you've got to be in complete equipoise until you see the results. So in fact, I think we both should agree, if we're proper researchers, that 10 years from now, we don't know whether we'll do the anastomosis, the Colon anastomosis is durable. We've got to wait for the results of these two studies. For the Meerkat study, we're going to look at endoscopic recurrence using the modified Rutger score. We're going to be blinding the assessors, and there's going to be central review by two surgeons. And I think that's really important to reduce that element of bias. There's also a mechanistic element to the Meerkat trial, in that we'll be tattooing the border, the mesenteric border, and seeing where that recurrence occurs. And that will give us some clues as to what is going on behind the sort of pathophysiology of recurrence. And I think actually I will just finish there. Thank you so much for your time.
Thank you very much for that. Dr. Michelasi, you have an opportunity to respond.
There is really not much to respond. I think we are in agreement. And one point that Professor Brown makes is that we really are in need of a standardized Rutgers scoring system for all this anastomosis. Now, also, if you like to do a staple anastomosis only, Bislengi has described a staple Cono S anastomosis technique. So it can be done stapled. I like to do it hands-on. As I said, the current evidence is encouraging but not conclusive. That's why we designed a randomized controlled multicenter study comparing the Cono S anastomosis to the side-to-side functional end anastomosis. And if there is time later on, I'd be delighted to describe how we have constructed it and when the data will be available. But I don't think that Professor Brown and I differ too much on the work that is in front of us, which is really to demonstrate in a prospective randomized control trial that this anastomosis indeed is as superior as the preliminary data suggest.
Thank you very much for that. Dr. Reguera, if we can shine a spotlight on you and please ask a question of both of the debaters.
Great. Well, thank you both. I think both of you actually agree more than disagree, so this is going to be easier for me, and maybe I'll just ask each of you at the end to tell us who you want to win the World Cup, although I imagine Professor Brown has already disclosed that, and Professor Michelasi, I don't know if you're still with the homeland of Italy and are grieving this whole time, but nonetheless, we digress. So as somebody who's studied postoperative Crohn's and used medications after surgery to try to prevent recurrence, maybe for Dr. Michelasi, I'll ask this question. How does the surgery prevent Crohn's without a medication? So I understand the mesentery, I understand the anastomosis, but this is an immune-mediated disease that we see systemic cytokine responses. And not to simplify it, but how can just one surgical technique prevent recurrence at such high rates?
Yeah, look, I don't have an answer to this very important, good, and provocative question. I don't have an answer. We're doing a corollary study along the Cono S study that we're doing by taking biopsies at the time of surgery of the intestine, of the mesentery, and by then taking biopsies colonoscopically later on to figure out really if there is a change that the Cono S anastomosis produces that is not produced by the side-to-side staple anastomosis. We are encouraged that we have 11 centers participating from Europe and the United States. The primary endpoint are endoscopic recurrence at 3-6 months and at 12-18 months from surgery. Secondary endpoints are endoscopic and surgical recurrence at 60 months. The COVID obviously has slowed down the enrollment. We're now at 270 patients out of, allow me 5 more seconds, 270 patients out of 360 total patients. As Dr. Messeris suggested, you need really 2 very large cohorts to have a statistical power. We think that we'll finish the enrollment in less than 12 months. So don't expect the data in March, Dr. Stocki.
Well, Professor Michelazzi, congratulations on running such an important study, and we look forward to this. And I guess for Professor Brown, what would the results need to be from the study for you to conclusively switch to CONOS for every Crohn's patient?
Yeah, good question. I think certainly it's got to be proved to be safe, and I've already hinted that I think we have enough evidence to show that that is the case, and it might even be that the CONOS anastomosis is safer than any other anastomosis, and if that is proven, then it doesn't really matter if it reduces recurrence, it might be the favored technique. I think you've got to see a statistically significant difference in terms of recurrence if that's your primary outcome. That's a statistical question that has not been answered yet. Another comment about the only randomized controlled trial that exists, Luglio's trial, it's pretty underpowered, I'm afraid. You're going to need more patients to prove it. Hopefully the combination of the study from Michelazzi when it comes out will give us enough power to be able to pull the results and say that there's a difference. And if it's statistically significant, then I would be inclined to favor it. But of course, I'd wait for the Meerkat trial as the most definitive trial. Thank you.
Thank you very much for that. Now we will move on to the next section. And the next section is 3 quick clinical questions. I will describe the clinical scenario, and then I would be interested if everyone gives a short opinion of what they would do with this patient, and particularly whether CONOS has a role in this particular scenario. So the first scenario is a 26-year-old female who has had a 10-year history of progressive worsening enteric Crohn's disease. She is cushingoid and has recently undergone a hip replacement for avascular necrosis of the acetabulum as a complication of steroid dependence. Her last colonoscopy demonstrated mild anal stricturing and a bluish discoloration of the perineum, but no perianal sepsis. She has an obvious sigmoid fistula with minimal mucosal inflammation and a very inflamed right colon. The ileocecal valve could not be intubated. Radiological findings demonstrate gross proximal small bowel dilatation, as you can see. In the lower image, you can get a hint of a distal ileal stricture and a suspected communication with the sigmoid colon. There is no abscess. There is suspicion of proximal small bowel strictures. If we can have Dr. Messeris and Dr. Crane and Dr. Hyman each give an opinion of what they would do with this patient, and perhaps we get Dr. Messeris to go first, and we'll try to keep it to a minute just in the interest of time. Thank you.
Yeah, so it appears that I didn't hear the medical thing, but it appears that the patient cannot, it has steroid-dependent disease, so it's unfistulizing, so there are complicated disease, so it's indicated to do surgery. It looks like the sigmoid is an innocent bystander, so we don't need to do a sigmoid resection, we just need to take down the fistula. I want to be sure that there's no anal stricture, and I would look very well at the imaging to be sure we don't have any strictures proximally, and then we would attempt laparoscopic, run the whole bowel from ligaments right down to terminal lumen, find then potential strictures, bowel preserving surgery with stricturoplasties for the proximal disease. I assume ileocolonic resection with taking part of the ascending colon, take down of the fistula simply with a endo-GIA stapler. Test the colon to be sure that there are no leaks, and doing an anastomosis. What kind of anastomosis? I still probably would do a side to side with mesenteric excision.
Thank you very much. Dr. Crane, what would be your operative approach?
Yeah, so I think Dr. Maceras really expertly outlined what all of the steps are. I think the only difference that we probably have is the technique of the anastomosis. I agree with bowel sparing when appropriate, strictureplasties, hopefully of the proximal strictures, a primary repair of the sigmoid as it does not appear to be involved, and then ensuring that there's no distal obstructions. In terms of the ileocolic, I would do the resection in the same way, either laparoscopically or robotically, and then do hand-sewn cono-S anastomosis.
Thank you very much. Now, Dr. Hyman, what would you do?
Yeah, no, I agree. The principles is that firstly, you don't have to deal with the enteroenteric fistulas per se, but you're going to strictureplasty all of the proximal small bowel strictures, and you're going to resect the disease that's causing the ileosigmoid fistula, and ideally primary repair the sigmoid colon, assuming it's technically straightforward. You know, with respect to techniques, one thing we didn't talk about is my own preferred ileocolic anastomosis is I do end to side. Very easy to get a scope for the GI person to get a scope through there. And back in the old days, you know, right, suturing of anastomosis didn't begin with cono-S. My colleague and esteemed colleague, Dr. Hurst, who Mukta knows well, sews these still end to end. And, you know, that's been reported even before the cono-S anastomosis. And I hope we can get back to the idea of studying the science and how, as Dr. Reguero points out, how is it possible that a surgical technique prevents recurrence? We need to understand a lot more and stop speculating.
Thank you very much. Thank you, all three of you, very succinct and useful points. Now, can we move to the next slide? This is the next clinical scenario. So we have a 23-year-old male who was diagnosed with enteric Crohn's disease 5 years previously. At that point, he had a laparoscopy for presumed appendicitis and was found to have inflammatory ileitis and a paracolic abscess, which was drained. He has been regularly seen by a gastroenterologist and treated with dose-appropriate infliximab. In the last 6 months, however, he proceeded to become lethargic, unable to tolerate solid food, and has lost up to 12 kilograms. His last colonoscopy demonstrates a healthy colon, rectum, and anus. The TI was intubated to 5 centimeters, but proximal to this was a non-traversable, severely inflamed segment of ileum. The CT imaging is concerning for a segment of terminal ileitis with a mesenteric abscess, and the mesenteric abscess cannot be drained easily under radiological means. So if we can have Dr. Holuba to speak first, and then Dr. Stocky and Dr. Silla. Thank you.
Thanks, Vlad. I think both of these cases really, demonstrate in the previous case, the patient was steroid dependent, and which is one of the biggest risk factors for an anastomotic leak. And in this case, they have a mesenteric abscess and potentially malnutrition. So, I think, we really need to think about these patients in terms of optimization and how much time do we have. In this particular patient, this has been going on for 6 months. So, all things being equal, and it sounds like he can tolerate liquids, if not solids. So, all things being equal, we want to, slow down, take a deep breath, and think about what we can optimize. Intravenous iron, exclusive animal nutrition would be my go-to in this person. 4 to 6 cans of a commercially available nutritional supplement for at least 2 weeks, 2 to 4 weeks. Often they have to wait 2 to 4 weeks to get on the OR schedule anyway. And in this particular case, oral antibiotics. Often we'll find that the combination of oral antibiotics and exclusive animal nutrition can really help to optimize these patients. And then I would be looking to do cono-S in this particular high-risk phenotype.
Thank you very much for that. I particularly am interested about the cono-S with a mesenteric abscess. Dr. Stocky, please.
Yeah, I share with Stefan the concerns about nutrition. I think when you said that the patient was lethargic, the first thing I thought is like, there's a chance I might not put him back together. I mean, I would need to see the patient, and I realize that this conversation is tangential to the cono-S debate, but I think that I would start antibiotics, and then if patient is a tennis coach, so probably not very quite fit, I assume, so he could take a hit, and if he looks like he can take an operation, and I would have to decide intraoperatively if I'm gonna put him back together. This is a patient that has a high risk of diversion, and I would need to decide intraoperatively. As far as the technique, if there's a boggy dilated proximal ileum, I prefer end-to-end hands-on. And I would think that in this particular case, that's going to be the case. And then I need to be prepared for bleeding and transfixion sutures in the mesothelioma. And then if we do a diverting ileostomy closure in 3 months.
Thank you very much for that detailed answer. Dr. Silla, please share what you would do, and if you have any other comments.
Yeah, just a quick comment. I commend the two speakers to mention optimizing the patient preoperatively. I think this is an excellent point that some people sometimes forget. So as much as possible, but our experience, at least at Mount Sinai, has been that those patients do actually better than expected in terms of being able to tolerate surgery, a laparoscopic approach, and a primary anastomosis without a systematic need of a diversion. And our data has shown actually equivalent anastomotic leak rate in this population. But the nutritional optimization, as much as possible, if the patient is relatively asymptomatic, is a good plan. I am intrigued by David Schweitzberg actually had a very good comment, and I think that's an important point, is we haven't really discussed the amount of small bowel being involved in the Colon anastomosis. So there's concern because we don't have long-term data on Colon beyond, the 35 to 55 months published to date. If the patient are going to have recurrence there, how much bowel will eventually be sacrificed in these young patients? And are we talking about 20 centimeter times couple times plus, resection of additional strictures? I think that's something to keep in mind. I think the long-term data will be important to make sure that we're not compromising patients in terms of, the risk of short gut in the future.
Thank you very much. David Schwartzberg is a co-fellow of mine, so I'm delighted that at least one of us is clever enough to impress you. Righto. Can we now move on to the next clinical scenario? So this is a slightly built 56-year-old lady who initially had an ileocolic resection in the mid-90s for stricturing and penetrating ileal Crohn's disease. She also has a history of perianal Crohn's disease, but it is currently not active. She has seen many gastroenterologists through the years. She reports intolerances of variable severity to multiple medications, including prednisolone, methotrexate, azathioprine, and infliximab. She has an end-to-side stapled anastomosis, which I personally am partial to, which is not traversable, however, and cannot be dilated. Imaging shows a 20-centimeter region of inflamed neoterminal ileum with some proximal bowel dilatation. If I can get Dr. Brown's opinion first, and then Dr. Michelasi and Dr. Aguera, please.
So an important point that's been made with the last case is optimizing the patient, making sure that they're nutritionally sound, making sure you've weaned their steroids down, and getting that sort of Goldilocks period where the patient's not too hot, not too cold, and then operating. In this patient, as long as they haven't had their previous surgery, haven't had too much small bowel resected, I would go for the easy option, which is to resect that 20-centimeter segment of inflammatory stricture with an optimized patient, and I'd put them in a trial. I would compare Colon with a standard anastomosis and a radical mesenteric excision with a close mesenteric ligation, provided that the mesentery wasn't inflamed so much that you were concerned about doing a radical excision, i.e. the inflammation wasn't at the root of the mesentery, which might make a radical excision more dangerous. So optimize the patient, put them in a trial.
Thank you very much. Dr. Michelasi, what do you think?
Yeah, no, I think very good points have already been made. I will not dwell on the preoperative optimization. Another one, maybe for residents and fellows which may be attending this debate, is that at surgery, no matter what the imaging shows you preoperatively, you have to examine the entire small bowel and possibly the large bowel, because occasionally you find additional strictures or additional Crohn's sites that preoperative imaging did not demonstrate. Now, in this particular case, it looks like the appropriate procedure is the one that Professor Brown indicated, which is a resection of the anastomosis and the 20 centimeters proximal to it, with most likely a primary anastomosis. I don't do CONOS outside of the study, so in the study only involves patients with primary ileocolitis. So this particular patient would get either an end-to-end or a side-to-side or some kind of a normal configuration.
Thank you very much for that. Dr. Ruggiero, can we please have a minute of your time?
So I think this is where we've realized that surgery is not a cure for Crohn's disease. And I think independent of whatever anastomosis we use, we need to be vigilant to post-operative management. So obviously we would want to make sure this patient's not a smoker. If she is, she must quit smoking. But Vlad, to your question, this is somebody that obviously I would defer to all of you what surgical anastomosis you do. I'm not sure I have a preference at this point. Obviously, the post-operative management's what I'm focusing on. So she's already had one surgery. This is her second. She's losing small bowel. She's had a stricture with a fistula. I would explore the next biologic. So even if you gave her a CONOS, she needs to be on medical treatment, maybe not infliximab if she's failed that, but then we could have a discussion about one of the other advanced therapies, and that's a separate discussion, but that's how I would approach this patient.
Well, thank you very much for that. That concludes our questions. Thank you all. Now, if I can get Dr. Galandiak to say a few closing remarks, please.
Well, I just wanted to thank both Drs. Bolshinsky and Brandstetter for organizing and coordinating the first ever DCR Journal Club. And I also want to thank our judges and the team participants on both teams for participating. And I hope the audience realizes the incredible caliber of both the judges and the participants. And I'm not really sure what factors are most responsible for Crohn's recurrence, whether it's the anastomotic technique, whether it's environmental factors. For example, where I live, nearly all my Crohn's patients are active smokers, despite what I counsel them, or if it's in the mesentery, as Dr. Brown thinks is so important, or a combination of all three. I hope that this is the first DCR Journal Club debate of many. And we're going to have a Twitter poll coming out once the recording is posted on our YouTube channel. And I hope many of the audience, both live as well as on the YouTube channel, will put in their votes regarding what things they think are important with respect to Crohn's recurrence. And also let us know who you think had the upper hand in the debate. I'd like to thank you all for joining us and hope you join us again at next month's Journal Club. And I want to wish all of you the best for the holidays and have a happy new year. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.
all. Good
Great
night.
job, guys.